Hello, my name is Naval Daver. I'm a faculty in the Department of Leukemia at the MD Anderson Cancer Center in Houston, Texas, and it's a pleasure to speak to you all today about some of the updates in AML therapy. The first thing I'll be discussing is how can venetoclax combinations improve outcomes for FLT3 mutant acute myeloid leukemia. Venetoclax, as most of you know, is a BCL2 inhibitor that has shown great activity in combination with both hypomethylating agent and low-dose cytarabine in frontline older unfit acute myeloid leukemia, eventually culminating in two randomized phase 3 studies, the VIALE-A and the VIALE-C study, both of which showed an improved outcome with a combination of HMA with venetoclax or low-dose cytarabine with venetoclax versus either HMA alone or low-dose cytarabine alone, leading to the worldwide approval of venetoclax in combination with low-intensity therapy in frontline older unfit AML. Now, in parallel, as these phase 2, phase 3 studies were ongoing, there were a lot of efforts to further evaluate synergy of venetoclax with other treatments. A lot of this preclinical work was done by Marina Konopleva and Michael Andreeff at MD Anderson, also Tony Letai and Dana-Farber and other experts across the world. And one of the combinations that preclinically emerged as being very exciting, showing synthetic lethality, is a combination of venetoclax with FLT3 inhibitors. In fact, there were 4 different preclinical studies done in 4 different institutions with different FLT3 inhibitors, quizartinib or gilteritinib, all showing very potent synergy and very low IC50s for this combination. And so that led to the clinical development of venetoclax with FLT3 inhibitors. This has been done predominantly in combination with the FDA-approved FLT3 inhibitor gilteritinib. Gilteritinib is a potent, generally well-tolerated, specific FLT3 inhibitor that is approved in relapsed refractory FLT3 mutated AML based on randomized phase 3 study from the ADMIRAL study. In the ADMIRAL study, the overall CRC rates were about 50% with gilteritinib compared to about 25% with intensive chemo, and there was also an improvement in median overall survival, and that led to approval of gilteritinib as a single agent in relapsed refractory AML. Although the 50% CRC rates were encouraging, the median survival was only about 9 months with gilteritinib, and this was in a first relapse primary refractory or first salvage FLT3 mutated population, majority of whom had not received a prior TKI with their induction. So there was a lot of interest to improve on gilteritinib single agent. Number of combinations are being looked at, combinations with hypomethylating agents, combinations with intensive chemo, both in frontline and salvage, and of course, the best preclinical data leading to a combination of venetoclax with gilteritinib. This was the study that we presented at the ASH 2020 and 2021 meeting. And in this combination, what we're seeing is that the overall CRC rates are significantly higher in the 75 to 80% range compared to the 50% seen with gilteritinib alone. The CR/CRI, or response with count recovery rate, is about 40% for the combination of ven gilteritinib, with additional 35-40% being marrow remissions without count recovery. The regimen in general is well tolerated, but we are seeing a theme that venetoclax-based combinations are often myelosuppressive, and this is true also for this venetoclax-gilteritinib combination. So while it's very effective at achieving marrow remission, and especially for patients below 70, 72 years of age with relapsed FLT3 AML, where our goal is to move them quickly to an allogenic stem cell transplant, this is an excellent approach. 75, 80% patients will achieve marrow remission within 1 or 2 cycles, and the plan would be to get a transplant lined up, move them to transplant, do post-transplant maintenance FLT3 inhibitor. And we do see in this population in our study who received Ven-Gilt, went to transplant, the survival at 1.5 years, the median has not been reached, and it looks very encouraging for a salvage population. Now, overall, the median survival for the entire population here was between 10 and 11 months. But we have to realize that this was actually a much more difficult population in the ADMIRAL study. So as opposed to ADMIRAL, which had only primary refractory first salvage, this study allowed all salvages. The median number of salvage therapies was 2 or 3, going from 1 to 5. In addition, most people in the Ven-Gilt study had received a prior FLT3 TKI with induction or prior therapy, about 60% as compared to only 10% ADMIRAL. So in spite of being a more advanced salvage, more prior TKI exposure, we're seeing much improved CRC rates and a signal for improved survival, and most importantly, molecular clearance, which I think in the future is going to become the primary way we monitor diseases, including FLT3, NPM1, and others. The molecular clearance rate was about 60%. This compares favorably to about 20-25% molecular clearance rates that we have seen with gilteritinib. So all in all, I think this combination is a very attractive combination, especially for patients below 70, 72 who are going to go to stem cell transplant. We're using this quite routinely. Now, of course, the question is, do we stop at the doublet of ven-gilt, or could there be a role to even develop a triplet? Because we know HMA venetoclax is effective. Could HMA venetoclax with a FLT3 inhibitor, either gilteritinib or quizartinib, be the next step? And not only in salvage could this be effective in frontline. So that's being evaluated. Dr. Short from our group showed some data at ASH in the frontline setting of the triple therapy HMA venetoclax gilteritinib. Small numbers, 15 patients, but 100% response, including 92% true CR rate. So even though there is an initial myelosuppression, more patients over time actually recover counts as compared to what we see with aza-ven or aza-gilt, where the true CR rate is about 40-45%, not 90%. So we do think both in the salvage setting, maybe with the doublet ven-gilteritinib, and potentially in the front line using a triplet of HMA ven FLT3, either gilteritinib, quizartinib, could be a very important step in improving outcomes for both these subsets of patients, and multiple trials are looking at this approach going forward, with eventual requirement, I think, for randomized study to look at the combination of HMA ven FLT3 versus HMA ven placebo to finally establish this approach in the frontline setting. Thank you very much.